Welcome to the Evolve Lactation podcast. I'm Christine Staricka, a board-certified lactation consultant in the U.S., and I create strategic lactation education for professionals who refuse the status quo. If you are involved in supporting and advocating for breastfeeding and human lactation, meet me here on the podcast for insights and encouragement. I've had a unique career in breastfeeding support, working in multiple types of settings, and I enjoy sharing my thoughts and observations with you. This podcast is about solutions, not complaints. It's about finding ethical, resourceful ways to solve problems and continue adapting to the ever-shifting landscape in which we work and live. I've got ideas, and I welcome some incredible guests onto the show to talk about their work. Grab your favorite drink or snack and settle in as we begin this next episode of the Evolve Lactation podcast. Well, hello, Olena. How are you?
Hi, Christine. I'm so happy to be here.
I'm so excited that we're finally doing this. I am super excited, everybody, to introduce you to Olena Dobczansky, our colleague, IBCLC. She's going to tell you a little bit more about herself and why she wanted to come on the podcast.
Yeah, absolutely. So, like Christine lovingly said, my name is Olena Dobczansky. I am a registered nurse. I am an internationally board certified lactation consultant. I've trained as a doula. I've been a childbirth educator with Lamaze for the last decade. And I'm passionate about quality and safety in maternal child health. So I have a certification as a obstetrical and neonatal quality and safety from NCC. So I have lots of letters after my name. And I've spent lots of time getting all those letters. I'm actually sitting for PMHC. But what I've realized in the last couple months, right, is the letters are very important, but they are just one bit of the picture, right? And so when I think about representing myself, introducing myself, I really have kind of started thinking about this question a little more. So I'll share one really quick anecdote about who I am.
Sure.
When I was in third grade, I was a Girl Scout, and one of the activities of Girl Scouts is to sell cookies. And it was the first opportunity I ever had to be in a business kind of transaction. I'm a little kid, right? But what we did was we went to my father's office in New York City, and I wrote a letter asking people to buy cookies. And I ended up selling the most cookies out of anyone. And so there were prizes and all this kind of stuff. But this experience really stuck with me because it was the first opportunity to really think about scale. And so then when I become a clinician, I have a degree in psychology, and then I became a registered nurse through a master's program. And in all of that education, right, I'm kind of saying to myself, like, who am I? What am I doing here? And in the background has always been scale. Right. So when you think about learning to be a nurse or learning to be a clinician, it is very one-on-one. It's your skill set, it's your abilities, it's your confidence, really providing care one-on-one to a patient or potentially to a group. But I've never really thought about care in that way. I've really been focused on scale for a very long time. And so I mention this because my pathway in healthcare has been, of course, riddled with potholes, just like I think most people's, right, is. It's not this idealistic, oh, I'm going to care for people and it is going to be my profession, right? I get compensated for care. There's more to it. And so within maternal child health, I just became more and more interested in subspecialties of subspecialties, which eventually obviously brought me to lactation, perhaps the most dynamic, in my opinion, of the maternal child health subspecialty.
I happen to agree.
We'll launch into significantly why I believe that to be true. But basically my trajectory really is work at the bedside one-on-one. I became an entrepreneur 14 years ago when I just saw, again, like a knowledge deficit. People needed CPR classes. I started building this into other offerings, infant massage, and then really fell in love with lactation, was a CBC before I sat for the IBCLC exam. And really, again, this idea of widening my own scope and widening the scale at which I can help people. So that is a very long-winded answer of who am I? I want scale, I want quality, and I am a clinician.
And you're always learning. You are absolutely a lifelong learner. You have found, the reason you're interested in subspecialty upon subspecialty is because you hear these things that don't match up in your head. And so you're constantly diving into something new and deeper that is going to always tie back to what you said in the very beginning, making mothers and babies safer and healthier.
Yep. Yes.
Everything that you see, that you do, and everything that you say, and everything that you write comes out with that in mind. So
there is definitely an intellectual curiosity that I cannot shut off. There is 100%. I love to read. My family has librarians on both sides. I was always around books. I think that the idea of having knowledge at your fingertips is just incredibly exciting. And now that we are in a very new chapter of what that really means, it needs refining, because now it's not a book. We have access to literally almost endless information. And so it's been really interesting, to your point, kind of refining my interests, matching that with certification as it reflects quality and safety. But then again, probing further, like, what do we not know? What do we know? How can we connect the dots?
Sure. I did a couple of speaking engagements a few weeks ago in Colorado. And one of the things that I really emphasized for those, I had two audiences. One was nurses, and then one was WIC personnel. Right. And we really talked about how this whole idea of information at your fingertips, what used to be the case even like 2 years ago in terms of how people are getting information about pregnancy and breastfeeding and postpartum health. You used to go online and you would Google something and you would get all the top websites and the information that was there. But now, since they've switched it over to the AI summary, you go on there and you get whatever AI thinks is the answer. And if you have taken any time at all to look up even just one topic having to do with breastfeeding, you will see that the AI summary is absolutely terrible. It is pulling all the wrong information, including things like commercial marketing messages and things from outdated flyers from hospitals. Like, it is wild out there.
100%. To your point, the problem is that we did nothing to address health literacy. So, right, your access has increased exponentially, but your health literacy perhaps is even worse, because now we have to contend with constantly new technology to be able to allegedly make our lives better. Now, this is the point of technology. Technology is something that quite literally, perhaps by definition, is supposed to make things easier, a process easier, make your life better. I'm not a marketer, so I'm not gonna whatever, but the idea is that the wheel made progress. And I think we do need to be incredibly careful about just clarifying what that means, right? An AI just is grabbing whatever has been thrown into it. It is not, despite its name, intelligent to be able to say that this is a care plan or your symptoms are here if it has not been trained in that manner. And that's what is both terrifying and also fascinating about the moment we're in, because clearly if we don't have people who are training models appropriately, we will get garbage in, garbage out.
Absolutely. And for that, to approach some of those problems that we've just talked about, you have created something which I think is incredible, and I want you to tell the world about it. Starting from the beginning, really with the what the model that you put it in and
Sure.
why you chose that model rather than just sending me a Google Doc of some bullet points.
Sure.
Tell us what you put together and why you did it that way and where we're going to go with this.
Sure. So I'm so excited to unveil and launch my Rogerian Ontology of Breastfeeding. So, audience, you must be saying to yourself, what the heck did she just say, right? Who's Rogers? What's an ontology? What is breastfeeding? And that's exactly what we're going to try to figure out here. Basically, when I think about my clinical work, I am someone who tries to be organized. And I would argue that any clinician is doing that in a myriad different ways, whether or not that's time management, whether or not that's skill set, whether or not you're aligned with evidence-based practice. So I kind of come to this with this just craving a framework. Christine and I are very aligned in that way. And so just to organize all of the thoughts that are swirling around in my head, I basically kind of was trying to understand what it is that I love about breastfeeding. What is it that not the act of doing it, because that is a separate conversation.
Separate conversation. Yep.
Right, totally separate conversation. The act of discussing and talking about breastfeeding is what I'm talking about, right? And so I'm obsessed with people's thoughts, feelings, and behaviors. I have been obsessed with this for a very long time, and then I sat in senior year in AP psychology, and she told me, this is what psychology is. It's the science of feelings, thoughts, and behaviors. And I was like, holy guacamole, bye-bye biology. So I mention this because what are we talking about when we talk about breastfeeding, right? We're talking about thoughts, we're talking about feelings, we're talking about behaviors, we're talking about physiology. And so what I started to notice in my years of education, whether or not that was in acute care, primary care, in the home, telehealth, I've done it all, is we need theory. We don't just need technique. We need an ability to be able to communicate and use language to get our point across. And you're saying to yourself, well, that's like literally what you're doing. You're on a podcast, girl. Like everyone is talking. That's all they do. But what you start to realize is in lactation care, in clinical practice, you have a lot of imprecise language that then affects the clinical care and care planning in general. So we'll just give a very classic example of milk production versus milk supply. Okay, so we now know there is not inventory on the shelf, right? There is not a bookstore of boob juice to access. That's what we want. That's what we wanted. That's the dream, but that's not how our physiology works. And so we have this vestige of this talking about a supply, right? Because the boob gets bigger, right? People who don't know much about the actual science will say, okay, which is basically what we had for a very long time and still continue to. But this idea of supply, right, is not really accurate when you're talking about the physiology. It confuses the patient, okay? But now milk supply means something else because we have the commercialized interests of feeding, and milk supply can refer to the literal inventory of milk you have in your refrigerator or in your freezer. So we really are not only have to be dexterous in our acknowledgement of what we're saying and what we're trying to communicate. If that is confusing, we're already starting off at not a great baseline, right? And then we take into account the idea that things change, right? If, you have a young kid, I can't even understand anyone 20 years old now, right? So like language changes, okay? I know I look young. You can't see me. It's okay, guys. Milk production is really more accurate. You need to constantly be producing in order to be making more. This is a very different concept than going to the grocery store and getting all your food once a week. Like that's a very different thing. So that's a classic example. I think my favorite one, next to the obvious one that I wrote my entire theory about, is latch. I hope everybody listening to this with your ears is with me, because what the beepity beep boop bop is latch. Latch is like a mechanical fastener. Anybody who like Googles latch, please do it right now. It's a literal door hook. It's a thing that closes a door. And this is really interesting to me because that's what it looks like. When you hop on the boob, you're latched on. But latch infers nothing about function. Imagine we are literally trying to teach someone about the efficacy of their feeding, and we are ignoring completely the only thing that matters.
Right.
So latch, again, that's what it looks like. It's what someone observed. It is we're so past latch, right? Like it doesn't offer any information, unfortunately, and it is harmful. It looks good. Boo-boo. You got a tongue that is not making any contact in the back. It's not gonna look, it's looking great, but it's not functional. Okay. And then this obviously brings us, my lovely Christine, to my absolute best example of imprecise languages and why definitions matter in clinical practice is what I wrote my theory about, which is the difference between breastfeeding and lactation. These are two distinct but overlapping processes. And as a result of conflating the two, we have big problems. And so my ontology, which is a theory of meaning, right? What is breastfeeding? What does that mean, right? We'll talk about who Martha Rogers was in a moment, but it is trying to explain that these are two separate things that need to be related together, but they cannot be used interchangeably. Breastfeeding is not the same thing as lactation. Lactation is the physiology of milk production and subsequent removal, and breastfeeding is not that. Breastfeeding is the relational health. It is the act, the health behavior of removing milk from the breast, right? And so these things are not the same. They cannot possibly be the same thing. The people who are stewards of both of these things are not the same person. We see when we start to make this distinction, and I'm not the first person to do this, I am definitely the first person to apply a nursing theorist lens to it. It is going to redefine the personal experience of what it means to lactate and to breastfeed and to pump. Because without these clarifying terms, we have clinical confusion, we have research misalignment, we have policy fragmentation, we have patient misinformation.
Right. And, that brings to mind the practical results or outcomes of that confusion and conflation. Because, for instance, the Baby Friendly Hospital Initiative ensures that mothers have access to quality breastfeeding support in the hospital. However, what we find in North America right now is that many mothers go home from the hospital already using a breast pump, or they begin to use one almost immediately when they go home, having received absolutely no information about how to express milk.
And I will tell you why, because I worked on a postpartum unit for years.
So did I.
And anyone who sees what goes on a postpartum unit understands individualized care is not it. You will receive the potential for personalized care, right? I'm speaking to you by your name. I address your baby by their name. That is not the same thing as truly individualized care. A registered nurse who is tasked with taking care of 3 patients times 2, which is 6. Let's say it's 4 or 5, maybe 6. Some dyads, there are no patient safety laws really, so anything goes. If you don't have a union, you're looking at higher patient ratios. They are on autopilot. There is nothing that delights a registered nurse more than a formula-fed baby. It's just the truth. And that's because it's a time management thing. I am talking about the profession. I am not talking about anything else. I'm talking about getting to your goals. If you have to be in 6 rooms at one time, you want one mom to be able to feed the baby without you, right? This is wrong. This is inappropriate. But this is also a vestige of the fact that a pump is going to solve our problem, right?
Right.
That a piece of technology, that something is going to be a panacea for our issues versus the education that you and I naturally will agree on this cannot happen in a hospital.
There's no time.
It
It
cannot happen
never happened.
postpartum. If you are a healthy person, if you had just standard interventions at a hospital, I'm looking at an induction, I'm looking at an epidural, I'm looking at all your just basics, and you are well and you are cuckoo cuckoo, you're still out to lunch. You just had a baby. You're
Right.
what? Excusez-moi? And then you're going to layer on preeclampsia, gestational diabetes, all sorts of preterm babies. I mean, back where I was, 37 weeks, unless they were getting sectioned at 39. Boom. Everyone's early. I mean, it's not what our conversation is about, unfortunately. So here is what I am really trying to zone in on when I think of the plea I have to clinicians, especially lactation consultants specifically, is think about your language. Reconsider the words that you use daily, because you need to make sure that the language you use is crystal clear. You might know what you think you mean, but if a term now has 2 meanings, like milk supply does, it's just a great call out to say, am I intending what I am supposed to be saying? And is the patient or the client receiving that information? And this is a perfect segue to, again, the foundress of my theory, Martha Rogers. Who was Martha Rogers? Martha Rogers is a nurse. She was a nurse. She was born in 1911. She died, I believe, in 94. So she had a long life in the 20th century. And she really did see a tremendous change in academic, medical, nursing care. And so she would have been a doctor. She was pressured to leave medical school because she was a woman. And then just really just dives completely into public health. She has multiple degrees. She has degrees from Hopkins and Columbia, and then essentially becomes a nursing professor. And she's at NYU for a while. And in 1970, Martha Rogers writes an incredibly influential book, which is a theoretical basis for nursing. And so if you know anything about nursing, nursing is different than medicine. Nursing is not medicine, although nurses speak medical. And this is where, again, our terms and understanding of what our scopes of practice are so, so crucial. But Rogers is really interested in basically removing this concept that health is this individual thing. She, in her public health work, really just starts to theorize about what it is, what health is, and what the role of nursing is. And so she basically comes up with this science of unitary human beings. And this is a wild theory now, wild in 1970. She basically is talking about the human environment being irreducible, that you cannot be a human being without your environment. They are an irreducible energy field. So this whole thing gets panned pretty quickly because it's very woo-woo, right? In certain circles, right? We're talking about energy. And think about when this theory is being written, 1970, right? The lowest breastfeeding rates, the highest intervention in obstetrical and pediatric care as far as we are vaccines, and like we see things are working and we're changing the narrative, yada, yada, yada. So she really is coming into this with pattern. She's obsessed with patterns. And so what she notices, again, in her public health work is that patterns are a lot more indicative of health rather than a lab value, let's say, right? And so she kind of thinks about this in wild, wild ways. But I take this and I think to myself, right, like breastfeeding and lactation are not static. They are the total opposite. They are dynamic, energetic processes. If you are a clinician who observes breastfeeding, you're a part of that energy field.
True.
I mean, I cannot speak for every lactation consultant. I can only speak for myself. I don't know if there is a personality test of who goes into this work, but it's like right? Like your little oxytocin radar goes up and like you're a part of this energetic relational process. But when a mother breastfeeds and lactates both, it is irreducible from the environment. Think about it another way. You and I are sitting recording this podcast. If all of a sudden I remotely started turning up the heat in your house, you start sweating, there would be some kind of response to your environment, right? And then I'd be like, oh, Christine, like what's going on with you? And you're like, I don't know, it's getting really hot. Because you're not aware necessarily of what is exactly going on, but your body is. Your body knows something has happened. And so what we're really seeing here is patterns of behavior that link this lactation and breastfeeding together. They are not the same thing, but they are related because you can lactate but not fully breastfeed. Mm-hmm. You can lactate but not breastfeed at all. I would call that pumping, right? Mm-hmm. You can lactate somewhat and then use an SNS to breastfeed fully. So we're just not thinking about this as holistically as possible, and as a result, the patient suffers. Our inability to not see breastfeeding and the physiology of lactation as patterns and not one specific moment to optimize, and I am guilty of this in my own practice 100%. I am still very much in this vestige of we're trying to optimize your experience, right? I want to make, literally the term I use is efficient and effective and enjoyable, the 3 E's, right? The baby should not be taking an hour to feed. They're using compensatory mechanisms. We need to look further. If efficient, effective, the milk should be going in. If it's not effective, then they're again using compensatory mechanisms. But this optimization language, I think, is less helpful. And I think it is more helpful to really think about the breastfeeding dyad as this incredible example of unitary human field patterning, right? Where the person who is nursing and experiencing that process sees what this is like. So now in the clinical practice, what does this look like? I went back to work and my production is down. Right? And you're like, okay, well, let's talk about what happened when you returned back to work, because it's not just separation from your baby. Right. We're all doing this already, right? Mm-hmm. We're all doing this already. My theory is to really kind of reframe breastfeeding to ensure that we're being incredibly clear about what we're talking about. Because the physiology is not what most people who call themselves lactation consultants are helping with. And then we've got the doctors who say they're breastfeeding medicine specialists, but they do not help with breastfeeding. They are really looking at lab values and they want to make sure you don't have a prolactinoma, and they're doing more of the physiology, endocrinology level, not necessarily care planning. Remove milk, XYZ, do this, do that, shmoo, shmoo, shmoo. And this is why we need everyone to come together, right? Like, I'm far from the first person to call this out, but I do think, again, the idea that we are headed towards personalization. Everything will be personalized to you, Christine. But we're defining what women's health is. Like, great, we're going to have all this data. Great, we're going to have the ability to see, there's, one of the nipple shields, you see the milk coming through. Okay, well, that's optimization without pattern recognition, right? Like if you notice, and I think again, we do this all the time, women specifically, because we are so cyclical in nature, right? The idea of making sure that people are getting personalized care will have to reflect two things in lactation care: their lactation, their physiology, and then their breastfeeding behaviors, to really try to get the best possible parental buy-in, right? Because it's so challenging. The parent doesn't know. We have all of these commercial influences, and this is why we need to define terms, because the banners of pumping is breastfeeding, it's not. Pumping
Right.
is
It's
something else. The
right.
baby's mouth is not on the boob. How can we be calling this the same thing? It does not even stand to elementary school level reasoning. It is not the same thing. It is different. We need to celebrate this. You are a literal guru on this. Pump injuries, like the insanity that happens as a result of that, that is a separate thing. It should be treated this way. To be honest with you, I believe that we really need consultants who specialize in pumping.
Yes.
We need consultants who specialize in this, who are aficionados, who have done either independent research, or there is a collective of people who are buying in, who say, we tested these pumps. That is not the pump company.
Yes. We still don't have that.
We have nothing.
After all this time,
Girl.
we still don't have objective research
We have nothing.
about products that are made to support lactation.
We have nothing. And I will tell you that as a result of my work in this field, we are losing buy-in. We are losing buy-in. And again, I would argue because breastfeeding exclusivity means nothing. That doesn't mean anything except that that person probably had a lifestyle and a body that facilitated this. Right?
It's a
We have no
measurement.
case support. It is not the health of the society. Now, again, this is getting in the weeds, because if everyone breastfeed, we would have a healthier society. I don't think anyone's arguing that. My point is the metrics that had mattered, because news to the audience, perhaps, there is no measurement of breastfeeding at the federal level right now.
Right.
Wednesday, September 24. No one is measuring anything at the federal level, my friends.
And
It
you and I
doesn't
live
matter.
in
It literally doesn't matter.
we live in big states where there
Yes.
still is public health.
Yes.
You know, looking at things like
I'm in New
this.
Jersey. Yep.
Many people live in states where there is also very little measurement or very inaccurate measurement of breastfeeding rates.
Sure.
So, you know, we've spent years picking apart, like, well, that's not the best measurement, or they don't do this right. It's not very accurate. The sample size is too small.
Right.
Well, now we don't have anything at all. I would rather have those back.
I agree. I think to the point of having metrics, yes, but again, I don't know. I can easily make an argument otherwise. We did nothing with this information because there was no buy-in around it. We were measuring exclusivity, and then nobody cares. Like,
It doesn't matter to an individual person. What matter, you know, their personal experience of breastfeeding is what matters to them. So for a person to be able to say what their breastfeeding experience was, like how much they breastfed or how long they breastfed, or is less important than how they felt about it.
You're hitting the literal most important point. Even someone who literally eats, sleeps, drinks this, okay? When it came down to breastfeeding my own children, I had extreme difficulties. Both of my children had posterior ties. My Redeemer baby, 17 months later, after my daughter, was more jacked up than she was. Again, I think the idea, do I regret breastfeeding? Do I feel any differently? It is a choice that I made. It was a health behavior I engaged in, and I had to make adjustments about that health behavior because my preference of what I wanted was not possible. It was not possible. So I think, again, you're setting yourself up for this idea of, when we don't measure anything at all, we obviously have no info, right? But I think exclusive breastfeeding is a good example of what does that mean, right? Because the individual, to your point, they have a very different experience of what it means to breastfeed and why they did it and whatever that is, right? But at the population level, what is it saying? Is it saying that this group of people had easier access? Did this group of people have support? Did this group of people work from home? Were these people affluently wealthy? Like, we don't have any information, and then it becomes a tool. Oh, well, we want to breastfeed, but then we end up combo feeding. Enter commercial influence. We know that people want to breastfeed, and then boom, guess who's there? Not clinicians.
Well, I would argue that the reason that this happened, the reason that these conversations became so reductive and not holistic and not accurate or clear in any way is because we allowed commercial interests to hijack this conversation.
Correct.
It used to be that breastfeeding was something that public health talked about, but nobody assigned a definition to exclusive breastfeeding or combination feeding or, feeding marketing. Other foods at whatever. It was just feeding. Yes. No one cared. Yes. Nobody paid attention. No one said the phrase exclusive breastfeeding until they started to notice that formula companies were totally in charge of making everybody
formula companies were going to feed their babies. Formula companies attacked exclusivity as a strategy for years, and then they pivoted. And you can, you've been in this business 20 years. I've been a clinician for 15. I can tell you like when it all went down. Like if you've been working with patients and like in this field, you can very much see like when Komotomo arrived on the scene and be like, oh, what the hell is this? Like they're trying to make it a boob. Like to all of the boutique formula that's going on right now, right? So it has been fascinating to, again, the nebulousness of terms, right? Breastfeeding, lactation, who helps what is what? They're not the same thing. If you have, but the behavior, again, has been reduced to production and transfer of milk. And so what we then see is it's not working. I need formula. Nobody's judging formula. But again, it's not working requires you to have the wherewithal to understand it's supposed to work.
Right.
You are literally, the difference now, and I really would say this, the difference now is not so much that formula has always been around, right? It's more so that they're like, yeah. Like the pump and the formula is already in the house. When I do childbirth education, for example, this is readiness, this is preparedness on some level, but it also is the acknowledgement that this is not going to work. It wouldn't be there otherwise.
Right.
It wouldn't be there otherwise. You wouldn't have purchased it if you thought it was going to work. And so that is the nature of commercialization, where yes, some people need to bottle feed, and that is a tool that those people need. But it is being marketed that everyone needs this versus the idea of really kind of understanding what feeding is. Because what you can't sell is relational, behavioral, cultural, identity-driven dimensions of feeding. And that is what someone who is working in the field hopefully is trying to achieve. The idea of relational health, that this is you and baby, that you and baby are irreducible, that you are one thing and you are affected by your environments. So, like it is an impossibility to suggest that someone is static, that someone is just doing the same thing and they're hoping for a result. No, we are multidimensional. And part of the thing that also transpires here, obviously, Martha has many dimensions of the theory that I expand upon, but we'll just pull one example, pandimensionality. Pandimensionality is the concept that what happened in the past is affecting your health right now.
Mm-hmm.
Mm-hmm.
Mm-hmm. Mm-hmm.
Mm-hmm. Yes. 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 Pandimensionality is probably the best example because it's so obvious, right? The 70s, nobody was breastfeeding. And now all of a sudden people are interested in breastfeeding, but we have literal genius marketers saying, look over here. I'll make your life easier. And then we got the sleep people being like, come over here, because you got to go back to work. And again, people are like, I need to try to be a modern mom. So what does that mean? It means personalization. How are we getting there? If we do not define terms, if we are not clear, if we are not looking at things not necessarily as optimization, but instead, because what is optimization? You climb the mountain and then what? You got to get back down, Christine.
You still have to be strong enough to climb down.
Really the catch 22, I think, with optimization. Obviously, you want the experience to be better. A clinician wants to provide a care plan where you are seeing improvements. Sure, I'm going to use the word improvement, right? But again, optimization of breastfeeding as a behavior is not something the clinician does, because it is a health behavior. It is a pattern. It is thoughts. It is feelings. It is behaviors. It is not just milk output. When we think about the technology that is being created now, it must have an ethical lens to it, because we have been living in a world where women's health is non-existent, and we have detrimental health outcomes as a result.
Absolutely. I mean, I have so many things that I feel like we could expand upon having to do with this. I think it all just comes back to the commercial part of it, and how we've let that dictate the conversation, and how we have all of these empty slogans that are masking
Correct.
what's really going on. Fed is best? What? That makes no sense.
All, it
Pumping is
literally
breastfeeding?
nonsense.
Where
Nonsense.
these things come from
This is what I
is
mean, though.
the best place. It's the best of intentions. It's wanting to comfort people who make decisions that they feel judged for. There is nothing wrong with comforting people who are feeling badly. But the problem is that the environment around them is what's making them, experience that. It's
Correct.
the same voices that are saying, nobody should tell you that pumping isn't breastfeeding, are also like, they're just getting to this from the wrong angle.
I think consultants will listen to this and say, this LC is saying pumping is not breastfeeding. What a wackadoo. Because
Well,
their patient population is almost exclusively pumping in some regard because of what?
okay, well,
Right? What is the answer to that? We don't
here's
know.
a way to think about it. If you are a lactation consultant listening to this, think about your own personal experience of being a lactation consultant. Do you have, and there's no right answer to this, and there's no good or bad. Just want to know, do you have more experience working with babies at the breast, or do you have more experience working with people who are using pumps, like separately? Personally, in my clinical experience, I have worked with breastfeeding more than I have worked with pumping. So that makes me more, more qualified, more experienced to work with people who are putting their baby to the breast, and less qualified to assist people who are pumping. So if I'm working with somebody who has a pumping problem that I cannot think of any more ways to help them try to resolve it, it's literally my responsibility, according to my credential, to refer them to someone else who has more experience working
Yes.
with pumping. If we don't say this now and admit this now, then we're shortchanging our patients. I would have no problem referring to somebody because I'm not an expert in low milk production. I mean, it's automatic. Why do we not look at this the same way and say, you know what? I am really good at helping people with bottle refusal or pumping or whatever. I
Yep.
am not as good with breastfeeding. Even though I'm an IBCLC, I'm going to send this person to that lactation consultant because that's their specialty. We can't go on saying these things are the same exact process because they're not.
They're not. They just aren't. And I think that that really is the bottom line. They just are not. We have to get with the program. We have to bring our language to meet the reality. Is the commercial influences are redefining the language of health.
Yes.
Again, this is profound. And I mention this at this crux because I'm applying my Rogerian ontology to really what is the future. Again, this hyper personalization where you have all this data on yourself. Who's what? What are we doing with this? How is it being interpreted? You really think you're bringing your year's worth of data on your Aura ring to your PCP? And he's going to be like, let me take a good 20 minutes to look at this. Like, what?
But at the same time, I'll tell you this. If you are a person who wants to wear a wearable that tracks all this data about yourself, and you are going to look at that data as often as you want to, and you are going to make changes because of the data that you're seeing and the patterns that you recognize, great. If you are going to say, I do not care about what any of that data means, like that isn't meaningful to me, then you don't need that. So the answer is not apps are, breastfeeding apps are good or breastfeeding apps are bad or breastfeeding equipment devices are bad. No, it's not good or bad. That's another reductive way of looking at this. So we're not trying to be, old fashioned like, oh, we can't have technology. No, but we have to approach this in the smartest way. And we have to, I think what you're trying to say here is that in order to approach it and in order to integrate it the way that it will be most useful, we really do have to go back to those fundamental definitions and the way we talk about breastfeeding and lactation.
Absolutely. It is point one to be able then to exactly what you're saying, organize, right? And say, I have this specialty. This is what I do. This is what you do. And we live in this virtual world. I mean, we really should be able to connect better, but we are not designed this way. We need to hone in on our patterns. Now, to that point, everyone has to be everything to everybody. I think clinicians in general are feeling this because the stress is significant. I think within the lactation world, again, because of at least the IBCLC, I'm sure other lactation professionals listen to the pod, but the multiple different entry points matter in who you get as those letters.
Yep.
Come on. I will explain that my own clinical practice is almost exclusively posterior ties. I almost always, I already know why I'm there. Now, again, people will hear this and be like, another person who just thinks is a posterior. I have 15 years of experience. I am an expert at assessment. I am exhausting. Trust me, exhausting every possibility because I do not want to tell a family this. Like, I don't want to tell them that. That this means that there is a complication. This is not something I want to say, but invariably, this is the reason why they're seeking me, right? They have either gone to someone who didn't understand what the process was to assess. They gave them a pump because, again, the solution to your problem is to keep lactating. No, the woman wants to breastfeed. She will continue lactating doing this, but you are not listening to what she wants. Right? Now, again, this may be incredibly challenging. You may have a lack of skill, or the patient may not be, I hate compliant, cooperative. There's a million reasons why everything goes to hell in a handbasket, right? But even there, you can see that by not addressing what these term means, the doctor is just a classic example. Oh, yeah, whatever, here you go. Like the baby's being fed. That's the best example of just a complete disregard for my health, right? If I hear that, right? Because the baby will be fed. Well, fantastic, but that's not why I'm here. And that's the problem with the pediatrician. Just straight up the problem with the pediatrician. The pediatrician is not your healthcare provider. They are not assessing you. They are assessing the baby. You're coming into the equation with, I have a problem, right? I'm noticing these patterns. That's the person who gets this information, and then they're disregarded. So they stop looking for patterns. They stop kind of seeing it as, oh, well, at 5 o'clock he gets really fussy, and it just doesn't work, and I have another opportunity to remove milk or to keep going or whatever it is. And again, when we think about personalization, how are we not going to have a world where we can nurse? That's where we're headed. I mean, I hate to be a dramatic Scorpio on this particular issue, but absolutely the idea would be commercialization is, unless you're commercializing the breast, which, hey, human milk's here, baby, right? Like, it is something that we can't move forward. We can't make 1 + 1 = 3 right now. We need 1 + 1 = 2, so then we can now add additional arithmetic, additional multiplication, yada, yada, yada.
Well, I don't think that we talk about enough in our culture that when somebody has a breastfeeding problem and something is preventing them from being able to breastfeed their baby, it's not just a practical problem to solve. Well, I'll get a pump.
It's a mental, yes, correct.
It's
You're
not
nailing
just, I'll get some formula and feed the
Correct.
baby. Like, that's a plan. That's a practical,
Correct, that's a
real
plan.
world plan
Yes.
for what you're going to do.
Amen,
But
baby.
that doesn't address anything about how it feels inside to fundamentally.
Or your lactation capacity, your literal physiological ability to make milk. In a posterior tie, it is classic. Mom has the capacity to make milk. They have the capacity to do this. When you have a baby with a restriction, it will be gaslighting. It will look like the baby is gaining weight. Mom is in agony. Baby is on for an hour compensating. And then again, you seek care and you're like, was any of this normal? And they're like, no, but here are your solutions. Well, what?
Right.
I have no lactation problem. I have a breastfeeding problem. I do not have a lactation problem. I don't even necessarily, right? Like, now we're reducing the baby to be separate, which we cannot do. The baby and I have a breastfeeding problem. It's co-regulation. It's relational health. This person gets what they get because of the interrelation that I have with them. Like, they don't, it's a must. It's parasympathetic nervous system activation. It's the oxytocin release. It's literally when you get a call, I get a call. I went back to work. I went on a work trip. I pumped twice, and all of a sudden I feel like I have no milk. What was the behavior you were doing? And now all of a sudden you have the effect, right? Like, yes, you need to go back skin to skin. You need to back snuggle your baby. You need to keep moving the milk because milk removal is what makes more milk. But again, your stress, how are we not talking about that as a part of the fact that your supply, your production, you're going to be affected. It's like, it's a distancing language, right? It's your supply or your production will be affected, not you, right, Christine? You will somehow be separate from the milk output. And this is what the theory really is trying to address, is you are not separate from boop.
Well, then, and
you're the captain of the ship.
How do we make it clear then? Because the situation, I mean, the way that things are set up now, clinicians are responsible for one person.
Correct.
Only midwives and IBCLCs are responsible for both people in the dyad when 100%. They care for you. And yes. I will also say an OBGYN, when the baby has first been born, they are also in that moment responsible, but not for a very long time. They very quickly are passing that responsibility on to someone else. But on an ongoing basis, you have a midwife or you have an IBCLC who is responsible to look at both and address both patients' complaints, symptoms, whatever's going on.
Yeah, that's
so,
So that is what the IBCLC needs to be doing. The IBCLC, as a credential, as a profession, needs to be screaming from the rooftops that we assess the dyad. If the dyad is not at the center of our care, you are a pump consultant. You are a pump technologist. You are a information, literally create a new thing. But we have to be clear with our language. If what you do every time you see a baby with a challenge is offer a pump as a standard operating procedure, you are not personalizing care and you are not assessing the situation holistically. I'm not saying that it may be warranted, but at the same time, you have to say to yourself, what am I doing? Am I assisting the dyad breastfeeding? Or am I now spending time, money, energy, business savvy to be developing a different aspect of my clinical practice? These are honest, ethical things that you got to say to yourself, because if you're telling people that you help people breastfeed, but then you don't actually do that, that is not great for us. Like, that's not great for the profession, of which we have to rally around, because this is what is giving us, hopefully, better quality care. And I will say this on the pod, if it is not translating to quality care, I will be taking my business elsewhere. Because it doesn't make any sense why you do the same broken thing over and over and over and over again.
Well, I'm also old enough to remember, and I'm been in practice long enough to remember, before pumps were widely available or accessible to everybody. So the option then was
last 10
use
years.
a pump and continue your lactation. It was, you're going to need to use some formula. Well, the problem now is that though it's wonderful that pumps are accessible and available, and they are a choice for many people, that is how they decide that they want to approach feeding their baby.
And as long as it's informed, God bless, baby.
Yes.
Absolutely.
I'm glad that we have better equipment, that we have better tools, that we have all of these wonderful things.
Yes.
But here's the thing. If you are that lactation consultant that you're talking about, whose answer to every issue is, here's a pump, we're going to get you started pumping, and that's what you're going to do forever. Why is that better than when all we had was, here's some formula, you're going to formula feed forever? Because both of those things ignore the fundamental part of, but I thought I was going to breastfeed.
They're flip sides of the same coin, Christine, and it all starts in the hospital with uneducated individuals sitting in the beds, okay? So the reality is when breastfeeding does not work, you have to give formula. Nobody is going to be like, no, okay? Now, that's because the baby's got to pee and the baby's got to poop before they get out of there. Right? So we're making sure that we're covering all our bases, because all of this is risk aversion and making sure we're documenting everything correctly. But now there's a pump on every floor because you're going home with a pump, because insurance has given you a pump. This is all ACA. So we've got the pump now as formula. It's the same thing. It's the same thing, except worse, because then when you get nothing out because the pump is not designed to work on colostrum and you have been inundated with IV fluid. Christine, I've seen 12 bags, okay? Like
16.
We are talking 16?
Yes.
And that's document, who knows what actually is happening. So literally, when that's then the message, this is gold right now. What used to be is you give a little formula and try to keep breastfeeding. If you want to keep breastfeeding, these are the options. You have to keep bringing the baby to the nurse, bringing the baby to the breast. Now we have work harder. You are literally bleeding lochia. The baby is 6 hours old. Pump, wheel it in. What? And even when you explain this is the problem. The interventions have happened. The intrapartum interventions have happened. This is why anyone who really, really respectfully is passionate about this, it can't last long in a hospital because it is so morally injuring to keep saying the same thing over and over and over again, but understand that your hands are tied behind the back. There isn't a fresh flange for my friend who needs a 16. This is not the world we live in. Like, right? Like, so, and again, hand expression takes work to teach. Or if you've even given someone a video, because let's be real, this is where we're at in education. Here, watch this video. I'll be back in 5 minutes because I got to go work on this person. Boop, bop, bop, boop, beep. I come back. Huh? Can you do it? Yeah. You needed a tactile experience. You needed something else. Like, it's not, but this all starts there. And so then you come home, and of course, well, it was working okay in the hospital. Another classic. Oh, it was working great in the hospital. No, it wasn't. Baby was barely latching, going, like that. But sure. Things are going well there. And now you're home, and it is a cluster beep. Right? And now you do need to pump because your breast is a watermelon. So what is the association with pumping now is a desperation. Is like, I am now have out of control anatomy and physiology that I need this tool for. I have absolutely no idea how to use it. It's going to cause drama on top of everything else. I think that's the part that is, even within this pumping conversation, like, the theory really does lend itself to acknowledging that pumping is different. Pumping is not breastfeeding. We have to take this back from commercial interests.
Yes.
It's a different thing. There is
It's
now
so hard.
pump companies. There's 400 pump companies. There will only be more. We're not moving towards, less. We're moving towards individualized, personalized devices, right?
But the reality is that pumping is hard and nobody ever tells people that.
No. And that's because, again, it is a solution to what, Christine? Lactation. It is not a solution to breastfeeding. It is not a care plan. I will be transparent with the audience. I exclusively pumped for 6 months with my son and was just living with all of my mental health stuff. Just being like, this is what my lifestyle is. Like, this is part of my lifestyle, is that I get up every 3 hours to feel like I have some kind of control over a situation I have absolutely none. And I have knowledge and I have experience, and none of that matters because of what you are saying. The visceral lived experience of breastfeeding is the only thing that you remember. I am not an analytical person by nature. In my business life I am, but not in my lived organic life. I never tracked how long I pumped. What do I like? It would have been insult to injury, honestly. Now, that's my own lived experience, and other people can use ways to mitigate, their lived experience and have it be positive. But I think that we're just creating a huge disservice to your point. It's hard. It's worse. It's harder. If it's an informed choice, vaya con Dios. But if it's not, and you really wanted this other thing, and now you are pivoting and making this other choice, it would be incredibly helpful to define what you're doing. Because again, your baby is not breastfeeding. I know that is hard to hear, but they're not. You are lactating and you are pumping. The baby is not at the breast. It is a different experience.
And it's also given this way of like making people, we've said for a long time, like, breastfeeding is not all or nothing.
Correct. And that's exactly what this theory tries to help explain.
Yeah, like you can do it once a day and still know, and still your brain says, I am a breastfeeding mother. I breastfeed. Like
I'll do one further. I would love if my legacy in this world was to change the idea of colostrum, that every baby gets colostrum. It is independent of your feeding choice. Okay? That this is not something you need to make decisions about. It is just what happens as intended, right? Okay? We're talking about a whole nother universe because are
Mhm.
you physiologically lactating? Yes, 100%. Is this a benefit for your baby? Yes, resounding yes. This is different than the choice to bottle feed formula. If you have been given you are making an informed choice. You want to stop you have still done a physiological process that has
Mhm.
benefited your baby that isn't breastfeeding.
But,
You
but,
feel
but,
me? You feel
let's
me?
not
Because there are people
forget,
who don't want to breastfeed. Okay.
right? But let's not forget, if you choose when your baby is born not to put your baby to the breast, you are still lactating
This is my point.
for
This is exactly my point.
days.
Yes, this is exactly my point. Exactly my point. Exactly my point. Now, again, we know culturally, some cultures throw away colostrum, yata ta ta, whatever, whatever, whatever. Education. Find the way that you're giving your education so people can make an informed choice. If they don't make your choice, that's on them. That's not your job, is to force people to make choices. It's
Education,
not.
that's what we do.
That's not your job. That is not your job. You are supposed to be giving information, and that language in which you are trying to communicate matters. If you
Hmm.
are trying to educate someone, again, on the benefits of the immunity, right? We have so many ways that we can use language to help get the message across. And this is why it's imperative to separate the behavior of breastfeeding may not be something that they want to do. But imagine the world where everyone gets colostrum.
Well,
We don't
instead
even know what it would look
we
like.
tell people you should exclusively breastfeed for
We
six
say shit
months.
like that all the time,
Six
pardon my French.
months? I don't know what my life's going to look like in 6 months.
This is
Why am
exactly
I
what I
making
mean.
a decision that's for 6 months? Can I
And
just
again,
make one for now?
lifestyle, right? It is a life. I teach breastfeeding as a lifestyle. And this is why a family breastfeeds in my way of explaining this. The father is part of breastfeeding. The mother is a part of breastfeeding. The mother also lactates, and that makes her special. It does, 100%. Right? But again, go back to the Rogerian idea of the environment, of openness, of integrality. Integrality means that when one thing changes in the environment, it has an effect on you and the rest of the environment. I mean, these are not ideas that are like super complex. It makes sense, right? But when you have a century-long medicalization of infant feeding coming at you, where it is clear that the baby ate this, right? It would be helpful to know where your actual problem is. Is my problem with my physiology? Is my problem at the breastfeeding level? And honestly, to clarify for lactation consultants, for ourselves as clinicians, where is your problem? Is your problem at the lactation level or is it at the breastfeeding level? Of course, these things are related, obviously. They're
Hmm.
just not the same thing.
Yeah, distinguishing too between the management of breastfeeding or the management of lactation versus the physiology and how those two are very different things. They can come together and make a really complicated milk production problem, or it can be just one of them that's causing the milk production problem.
Of course. And again, when you do clinical care and you see how the dyad fits together like a puzzle, it does just color your experience. I remember seeing a patient on the higher acuity side several years ago, and this woman had a nipple, truly was several inches long. And her baby had a restriction that was visible from outer space. I mean, truly, truly visible from outer space. You could see this puppy from Sputnik. So the mom puts the baby on the breast. I'm saying, how does, what's your experience like? Tell me what you feel. And she's like, okay, okay. It's not, I'm expecting it to hurt. But she's saying no. This baby is literally got so much milk in his mouth because this is mom's fifth kid. This mother has anatomy that is going to facilitate breastfeeding. Now we're talking about clinical assessment and where is our line, right? You can't promise the future. You can't tell somebody that it's going to be this, this, and this, right? And so as a result, it's incredibly imperative to really assess the dyad to see what the pattern will look like. In this particular pattern, this was working in this moment. I'm not coming in to say that you have a baby with a tongue tie. A, she probably already knows, but B, that was not my job there, right? The job was to assess her feeding, right? And in that moment, I really said to myself, well, yeah, this kid will probably have articulation issues. But this moment, this breastfeeding moment is working. This is the opposite of what most people see. Most of the time, it's not working, and we see compensatory mechanisms. When you see compensatory mechanisms and it's working, that is the most rare in my clinical experience. Where there is, where again, fifth kid was probably would not have happened with the first one. It takes the history. It takes getting to know people. It takes really being clear to be able to really further all of the things that we need to further: research, policy, and clinical care. If we're muddling terms, it's just, we're already been, we will be felled by commercial interest, to be honest with you, because that is who will define health. And we're just,
that's the cautionary tale. Yeah, that's the cautionary tale of this whole episode, really. And I mean, we can go on forever and ever, but really that's the key, is that we have to be, I hesitate to say this, but I mean, what I said before about my clinical experience being more weighted toward babies at the breast really is, it informs my bias. My bias is that breastfeeding, feeding at the breast, can often adjust, correct, and influence other things that are happening in lactation in ways that we do not yet understand.
Sure.
So if we focus on breastfeeding at the breast, can often resolve other problems that people are having. If we continue to leave it out and pretend like it's not important to us or to the process or to the mother, then we are missing out on important parts of that whole entire experience of, sort of shoving people down this path of lactation, of continued lactation through expressing milk only, without the opportunity to bring the baby to the breast, whether or not you believe in your heart of hearts that the baby is getting any milk there. That's different than breastfeeding is everything. It's both believing your baby is getting milk. It's also putting your baby to the breast when you think they're not getting any milk. And people do this. People do it around the world. People do it all the time. People do it with newborns, and they do it with older children, and they do it for a host of reasons.
Absolutely.
And all of those things are getting drowned out in our culture by the commercial messaging. So that's what I don't want to see happen. And that is why I continue to be a breastfeeding biased IBCLC. And I don't, I guess I don't think that's a bad thing, but I know that some people will judge me for that. But I don't think
you're rare. I think you're rare. I think that if you're entering this field now, it is impossible to really have the start that you did. We are inundated with professionals who have shown us that pumping is a socially appropriate way to remove milk, and breastfeeding is still not. And so this is where, again, this becomes, we have to define terms, because if we're talking about relational health, we're talking about personalized, equity-informed, evidence-based care, like all those buzzwords and all that fun, cool stuff. But like, truly, if the parent is not able to see the difference between the levels of where there can be issues, you're just gaslighting someone, telling someone that they can continue lactation without a real psychological plan of like, this is a lifestyle, like this is like, do you want to have other options? Because so often it is so final. It's just, I am pumping, this is now my identity, I am breastfeeding because that's what they're telling me I'm doing, but it's so far removed from the multi-dimensional health behavior, which, and I'm not saying pumping it, like pumping itself is just a task, I'm not assigning value to that,
but it's also a multi-dimensional health behavior in
right,
in
right,
itself,
but like
in
which,
and of itself.
correct, in and of itself, exactly. It just deserves its own thing to be able
It
to
does.
appropriately counsel people,
Yes.
correctly. Again, just straight up, how can you possibly know everything about every pump? And then, unfortunately, you get caught up into biases, right? So,
Hmm.
I've got a brand that I really don't like I really don't like. And I am trying to say, okay, maybe this person has a good experience, but then 10 people tell me this is absolute trash and it's destroyed their entire breastfeeding experience. Well, your pumping experience destroyed your breastfeeding experience. Now we see that there's a difference,
Hmm.
right? We see
Right.
for some,
Right.
in certain moments we see the difference and we see it for what it is. But I think it would just go a long way to set the table. I think foundations are crucial. I think frameworks are, when you spend a lot of time thinking, especially about the dynamic nature of human health and starting life, casual philosophical things. I mean, how's philosophy not going to come into this? So I think, if you don't believe in my personal, or you don't agree with my Rogerian ontology, I do challenge listeners to ask themselves, what is your own ontology? What does breastfeeding mean to you? How do you
Yes.
educate about this? What if any, is there a difference from lactation? I would welcome conversation and discussion about this as I publish my little ditty here. But yeah, I think the concept is to ask questions and to ask yourself, what does this mean to me as a clinician, as a representative of public health, and to try to advance breastfeeding, because we are under fire from our own. So we have to really be strong in our individual sense to then be able to approach an organization, like organizing, right? That was kind of the beginning of our conversation, that
Right.
LCs should specialize in pumps, and this LC specializes in, submucosal posteriors, and this LC, right? Like that's we're so far from that because we cannot even agree on the meaning of our terms.
Sure. And that's a great call to action, for you to get into conversation about how you believe breastfeeding is in this world and what it would take to change it if you feel like it needs to be changed. And I think you had another call to action actually in the ontology. I just want to make sure you have the opportunity
Yeah, let me.
to, leave everybody with the most important messages that come out of it. And
Yeah.
I hope we can have another conversation about this because
Oh, honor.
this, I mean, hopefully everybody is enjoying this enough to listen to the whole thing. I'm enjoying myself because I love nothing more than to talk about breastfeeding. So, what
Yeah.
else would you like to leave everybody with?
Just in terms of clinical implications, again, by distinguishing lactation and breastfeeding, I think you're really just creating a better path forward for your own practice. And then obviously for the collective good of everyone who shares your credentials. So we think about personalized models. We really want to move past this idea of optimization for optimization's sake. It really should be this idea of pattern recognition. We are our brains are trained to look for patterns. I think if you have an 18-year-old mom versus a 40-year-old mom, they are all looking for patterns. I think this is a natural way. We do have applications like trackers that are also kind of highlighting this, right? So you can really leverage technology potentially to look for patterns. This is something to consider. But just to integrate, again, the idea of making sure that you have when you speak to someone, you are very clear in what you are trying to communicate. But your job is essentially to translate a story and then provide a plan back to the person in various, I'm sure people have different titles and different scopes of practices, but that's a general concept of a transaction of healthcare, right? Is I have knowledge, you have a problem, and then we trade back and forth. And so just exploring this idea of relational physiology, right? We often say you don't bond with your pump, you bond with the baby. This idea of making sure that breastfeeding is not just milk removal and optimization of that process. It really explores the relational health. What does my baby look like? What do they feel like? What does my breast feel like? What are all these patterns look like holistically? Do I see this noticing this during the day, during the night? Those kinds of things. And just being able to teach more to the lived experience and how this is telling a narrative holistically rather than this is a separate part of your life. Like I go breastfeed in my little hobbit hole and then I come back out and I reintegrate into my life, right? Because that's what it kind of feels like. It can be, as we well know, for the experience of a breastfeeding mother, ironically, but maybe not, isolating, right? Where you're with this other person and it's still like, I'm the only adult in the room. So really holistically looking at just the behaviors and the open patterns and the environment. Martha Rogers and the Rogerian Ontology here is really focusing on the irreducibility of your environment as you exist in the world, and that being what health is, versus I have a total cholesterol of 200, right? Or I'm a diabetic or whatever, right? Like you are more than just the sum of your parts. Like, and then when you add another person and your health influences that other person's health, you really do see it, which is why breastfeeding is incredible.
Beautifully stated. So I invite everybody to tell us how this episode made you feel. Olena and I both are on LinkedIn, and we love to write as much as we love to talk, believe it or not.
Yes.
So you can find both of us there. I'll put some links in the show notes for you, and we are looking forward to part 2 of this at some point. Yeah, part 2 is coming, we're telling you. But let us know how you're feeling about it, what you think, and what you would like to see in the future. So thank you from the bottom of my heart, Olena, my friend.
An honor.
Wonderful to have you here. Really, really appreciate it. And we will talk soon.
Absolutely. Thank you so much, Christine. And to your audience, thank you so much for listening.
Thank you for listening to this episode of the Evolve Lactation podcast. If today's conversation sparked something in you, whether it's a new strategy you want to try, a policy you want to challenge, or simply the reminder that you're not alone in this work, take that energy and run with it. Remember, real change happens when committed professionals like you have the resources and community support to act. Join my community at evolvelactation.org for ongoing discussions, exclusive free resources, and connection with other people who are doing this important work alongside you. You can find all the links in the show notes and connect with me on Substack or LinkedIn for more insights and updates. Whether you're just starting your lactation journey or you've been advocating for families for years, your voice matters. Your expertise matters. And together, we're not just evolving our individual practice, we're transforming the entire system. Until next time, keep evolving.